Hello guys, hope you're all doing good. This is Dr. Agalya Kunandivelu, your organic faculty. Today we are going to have an intensive revision session on obstetrics with image-based discussion as well as difficult concepts. Right? Shall we start? Now we'll be starting right from anatomy. I'll be including anatomy, embryology, physiology, then and there wherever needed. Right? Okay. So one of the most important artery we have to discuss in obstetrics is this internal iliac artery. Right? So, we all know internal iliac artery arises from the common iliac artery, which in turn is a branch of the aorta, right. So, internal iliac artery branches are very frequently asked in obstetrics, okay. You have to know all the branches. Like before seeing the branches, let me tell you the most common mnemonic that is used for the branches of internal iliac artery, okay. So, it is I love going places in my very own umbrella. Okay. First let me expand this, then I will tell you, right. So, we have the iliolumbar artery, lateral sacral artery, gluteal artery, that is your superior gluteal, right. It is your superior gluteal artery, then your pudendal artery, inferior vesical artery, then it's your middle rectal artery, then vaginal artery, obturator artery and your umbilical artery, and here keep in mind uterine artery as well. Okay, because this is seen only in females, right. So, it is I love going places in my very own umbrella. Clear? Right. Now, what you have to know is the first three things, that is ILG, I love going, are the branches of posterior division of internal iliac artery. Okay, whereas the rest of the things are going to be the branches of anterior division of internal iliac artery. Is that clear? Right. Now this is also important. After uterine artery is coming, it will be ascending up, okay, right from the uterus-cervical junction, it will be ascending up and it will be giving branches as it passes along the lateral wall of the uterus on either sides, right. So, the branches in which order it is given is remembered as ARBS, okay. So, first is the arcuate artery, this one, then your radial artery, this one, then your basal artery, then finally your spiral artery. Clear? So, this was also asked in one exam, right? Yes. Now, yes. Now, coming to the types of pelvis. Types of pelvis. We have 4 different types of pelvis. First, let us identify what are these types. Then we will discuss the importance of each type of pelvis, right? Okay. Now, when you see, this is the inlet, okay, the one which is marked in blue color is the inlet shape, okay. So, in the first one, if you see, the inlet is somewhat round in shape, right, okay. So, this is going to be a, yes, very good, gynecoid pelvis. And in the second one, you are able to see that this is somewhat heart shaped, right. So, this is going to be a android pelvis. And the next type has an inlet which is anteroposteriorly oval, okay, this is somewhat oval, right. So, this is going to be your anthropoid pelvis. And finally, you have an inlet where it is transversely oval, this is going to be a platypelloid pelvis, right. Now, let us discuss the importance of each type of pelvis, right. So, first we have the gynecoid, android, anthropoid and platypelloid, okay. So, remember, gynecoid pelvis is a typical female pelvis and it is the most common type of pelvis, okay. female and most common. Android pelvis is the male type pelvis. Okay, this has a heart and shaped in it, right? So the boys have a good heart. Okay, then anthropoid pelvis is a ape-like pelvis, and platypeloid pelvis is a flat. It is a flat bowel-like pelvis. Right? Now, the transverse diameter in gynecoid pelvis is going to be slightly more than the anteroposterior diameter. Okay? Then in android pelvis, it is somewhat more than the anteroposterior diameter. Okay? And in anthropoid pelvis, it is the only one type of pelvis where your anteroposterior diameter is going to be more than your transverse diameter, and in platypeloid pelvis also your transverse diameter is going to be very much more when compared to your anteroposterior diameter. Clear? Now, as we see the pelvic side walls, okay, in gynecoid pelvis, remember this is the most common type of female type of pelvis. Okay, so females have to give childbirth. For that, pelvis has to be adequate. Okay, so what will happen? The pelvic side walls will be straight and parallel. In android pelvis, the pelvic side walls are converging. In anthropoid pelvis, the pelvic side walls are straight and parallel, but it is narrow. And in platypeloid pelvis, this walls are diverging. Clear? So, this is about the pelvic side walls, right? And the next one is ischial spine, prominence. Prominence of ischial spine. So, how will be in the gynecoid pelvis? Will ischial spines be prominent? No. So, it is not prominent in gynecoid pelvis. Whereas, in android pelvis, yes, it is going to be prominent. Prominent ischial spines are seen in android type of pelvis. Whereas, in the other two types also, these ischial spines are not that much prominent. Clear? Now, coming to the obstetric significance in the four types of pelvis. Okay. It is your gynecoid, android, anthropoid and platypeloid. So, when we talk about the obstetric significance, in gynecoid pelvis, it is a normal female pelvis, so there is no difficulty in labor. Okay, and the most common position we have is left occipito-transverse or left occipito-anterior, and yes, normal delivery is possible with gynecoid pelvis, right? And in android pelvis, if you see android pelvis, engagement will be delayed in case of android pelvis, and what happens is there are chances of deep transverse arrest, okay, deep transverse arrest, or there is chances of persistent occipito-posterior position in case of android pelvis, okay. But yes, normal delivery is possible, but with difficulty you may need instrumental delivery also, right. So, there are chances of instrumental delivery, but it can be difficult also. Okay. Next is anthropoid pelvis, right. In anthropoid pelvis, diameter of engagement is going to be, in anthropoid pelvis, the diameter of engagement in the pelvis is going to be your anteroposterior diameter. Okay. So, here you will get direct occipito-posterior position. Okay. That is more common, and there are more chances for non-rotation also. More chances of non-rotation are also seen with anthropoid pelvis. So, what you will get here? There will be chances for face to pubis delivery. Okay. So, there are more chances for face to pubis delivery in your anthropoid pelvis. Coming to platypeloid pelvis, what happens here means, here also the engagement is delayed. Okay. Here also the engagement is delayed, and the head will be engaging in the transverse diameter, because we know this is a transversely oval pelvis, right. And what you have to remember is, in all the 3 types of pelvis, the fetal diameter, okay, fetal skull diameter which is going to engage is your biparietal diameter, which is going to be 9.5 centimeter. Whereas in platypelloid pelvis, since this is a transversely oval pelvis, the fetal diameter which is going to engage is your super-subparietal diameter. Okay, this is going to be a super-subparietal diameter. So, this will be around 18.5 centimeters. Okay, suppose if the head is able to negotiate this diameter and can deliver, means it can deliver. Okay, there will be chances of asymptotism also. Suppose if it is not happening, means then normal delivery is not possible. Clear? What you have to remember is, it is a transversely oval pelvis. The head will be engaging in the transverse diameter of the pelvis, and then the diameter which is getting engaged here is the super subparietal diameter of the fetal skull, which is about 18.5 centimeter, whereas in the other types it is going to be a biparietal diameter which is 9.5 centimeters, and there is chances of asymptotism with this type of pelvis. Is that clear? Right. Now coming to asymptotism. Let me make this clear here itself so that you won't be having any doubt till the session, right? So, normally what happens means, when a fetal head is engaging, you have to check into the sagittal suture. Okay, I will be discussing fetal skull separately. For now, remember the sagittal suture of the fetal skull will be lying in center between the sacral promontory and the pubic symphysis. Clear? So, another point is that normally both your parietal prominences are going to present when the sagittal suture is going to be in the center. Suppose head is moving towards one side, say either the sacral promontory or the pubic symphysis, what is going to happen? Any of the parietal eminences will be presenting. Okay, so like this. Clear? So, I will make it a clear picture for you. Yes. So, first let me tell you what is symptotism. Okay. So, symptotism means 2 points we have. Okay. First one, sagittal suture is in the center. Second point is both parietal bones are at same level, right? Yes. So, these 2 points has to be kept in mind. This is symptotism. And when we talk about asymptotism, whenever these 2 points are not happening, then it is called as asymptotism. And we have 2 types of asymptotism. One is your anterior asymptotism, and the next one is your posterior asymptotism. Okay. In anterior asymptotism, anterior. Okay. So, anterior parietal bone presence, or it is lower. What happens in posterior asymptotism? Yes. So, posterior. So, posterior parietal bone presence. Okay. Then, what about the sagittal suture? Sagittal suture in anterior asymptotism is near the sacral promontory, whereas in posterior asymptotism, sagittal suture is near the pubic symphysis. Okay. So, just if you see this picture, you will be able to understand. In anterior asymptotism, the sagittal suture is going, the head is going towards the sacral promontory, whereas in posterior asymptotism, it is coming towards the pubic symphysis, right? Yes. And the next point is that anterior asymptotism is most commonly seen in multigravidas because of lax abdomen, whereas posterior asymptotism is commonly seen in primigravidas because we have a tense abdomen. Okay. The other name for anterior asymptotism is Niglis obliquity, okay, whereas for posterior ascentalism it is Litzmann's obliquity. Clear? Right. Now, let us learn about the pelvis in detail. So, first what we have to know is, this is also one question, okay. So, whatever I have taken, it is a question somewhere in some exam, okay. So, we do not know which concept will be tested in whichever exam you are taking, either FMGA or NEET or NEET, okay. So, it is better we learn all the important concepts here, okay. So, here what is happening is, the pelvis is divided into 3 parts inside, right. So, we have the inlet, okay, then the mid pelvis and then the outlet, okay. In the mid pelvis or the pelvic cavity, we have 2 dimensions. One is the plane of great pelvic dimensions and another is the plane of least pelvic dimensions, okay. So, the space that is present between these 2 layers, that is the plane of the great pelvic dimensions and the least pelvic dimensions, is known as mid pelvis, okay. This area alone was shaded and it was asked in an exam, right. So, the plane of great pelvic dimensions is present at the level of S2, S3, whereas the plane of least pelvic dimensions is present at the level of S3 and S4, okay. So, what is the importance of this area means, the plane of least pelvic dimensions takes importance because there are chances of so many things, because this is going to be the least dimension that the fetal head has to pass through. There can be chances of obstruction or other complications. It also has some other importance as well, okay. Now, let us discuss the importance of this plane of least pelvic dimension, okay. So, importance. First one, it is the site where we give 0 station, okay. So, as the fetal head is descending, we give different stations as the fetal head is descending, right. So, the 0 station is given at the plane of least pelvic dimensions, that is one point. And already I told you, this is going to be the narrowest dimension that the fetal head has to pass through. Then, this is where deep transverse arrest also happens, because if it is not able to pass through this narrowest dimension, then deep transverse arrest can happen. And also, when a normal mechanism of labor is happening, the internal rotation will be taking place at this site. And finally, this is the site where you are going to give your pudendal nerve block, okay. And also, this is the site of origin of your levator ani muscle. Clear? Right. So, this is the importance of this plane of least pelvic dimension. You should know what is mid pelvis as well, right. Now, let us learn about the diameters, okay. You have to know that each level will be discussing about 3 diameters, okay. One will be your anteroposterior diameter, another one will be your transverse diameter and another one will be your oblique diameter, and it will be learnt at the level of inlet, at the level of mid pelvis or cavity and at the level of outlet. Clear? Right. Now, so we are going to talk about the diameter in centimeter and the pelvis, okay. So, the diameters what I told, which can be anteroposterior diameter or transverse diameter or oblique diameter, okay. Then we have the pelvic inlet, then pelvic cavity and outlet, okay. If you remember this table as it is, then it will be very easy to remember all the values, okay. No need to follow any other technique. See, when you put this table properly, then you will be writing 11, 12, 13 like this, okay. So, in this direction first, then you will inverse it and write. So, it is 11, 12, 13, then you give 12 all in this row, okay. So, it is 12, 12, 12 and finally here 11, sorry, here also 12 and you do not give anything here, okay. So, that is it, okay. So, this is how you remember. This is very easy way. If you are able to construct this table, no need to remember everything in like it will be confusing, right? So you can remember this much easily. Okay, so you have to know that we have the antero-posterior diameter, and this is the transverse diameter, and something called oblique diameter. Okay, so I'm not going to discuss in detail everything because this is a revision session, that too with the high yielding images. I'm not going to touch everything in detail, right? Okay, now, so what is being measured here? Yes, we are measuring the diagonal conjugate. So two conjugates are important when you see at the level of inlet. Okay, so what we have is, we'll be doing pervaginal examination and we'll be trying to touch the sacral promontory. Okay, so at the level of sacral promontory where your finger touches, you have to just keep the other finger, take it out and measure the distance between the end where the pubic bone touched and the end where the sacral promontory was being touched. Okay, mostly till the middle finger, right? So then this measurement will be taken. Can you understand? Yeah. So this will be your diagonal conjugate. What you are measuring is your diagonal conjugate, because true conjugate is something. Okay, so true conjugate means it will be passing from the pubic symphysis. Okay, say everything has a common ending, that is sacral promontory. Sacral promontory is the common ending, that is the most prominent point on the sacral promontory. But what is true conjugate means? It will be passing from the upper portion. So let us move like this. Okay, I used to remember like this. Okay, so it is dot. Okay, so you have to write it down. So it is dot. So what we are measuring is the diagonal conjugate. So diagonal conjugate means it is from the lowermost part of the pubic symphysis to the sacral promontory. Okay, then obstetric conjugate. Obstetric conjugate means it is from the middle portion of the pubic symphysis, back side of the posterior side of the middle portion of the pubic symphysis to the sacral promontory. Then true conjugate means it is from the upper portion of the pubic symphysis to the sacral promontory. Okay, so finally everything will be having a common endpoint, sacral promontory, and whatever you have measured, okay, from that only you will be able to calculate the other two conjugates. Okay, but the most important conjugate here is, sorry, it is conjugate. The most important conjugate here is your obstetric conjugate. Okay, so whatever you have measured, for example, the values will be taken like this. Okay, so obstetric conjugate is nothing but your diagonal conjugate minus 2 centimeter, say roughly. Okay, then true conjugate means it is your diagonal conjugate minus 1 centimeter. Okay, your approximate values will be like this. So diagonal conjugate will be around 12 centimeters. So obstetric conjugate will be 12 minus 2, that is 10 centimeter. And then true conjugate means 12 minus 1, that is 11 centimeter. Another way to remember this easily is O for O. Okay, so 0 for O. This is easy. And di means it is 2. T. Okay, so this looks like 1, right? So this is 11. Clear? You shouldn't forget these measurements also, right? Now coming to the next one. Okay, so this I have kept because you have to know how a normal pelvis is looking like. You are able to see that you have a sacral bone which has 2 ala here, and it is going to join to the innominate bone or the hip bone. Okay, so you have a sacroiliac joint here, right? So in some anomalous pelvis, okay, so like this, we have 2 anomalous pelvis. The first one is a Robert's pelvis and the second one is a Neagley's pelvis. Okay, so how you remember is Robert's pelvis and Neagley's pelvis. Neagley's pelvis means an means single. So it is n means Neagley's. Okay, so 1 Neagley's. So 1 ala of sacrum is absent means that is going to be your Neagley's pelvis. So obviously Robert's pelvis will be both ala absent. Both ala of the sacrum is going to be absent. But however, Robert's pelvis is an extremely rare abnormality. It is an extremely rare abnormality, and the sacrum is going to be fused directly with the innominate bones. Okay, whereas in Neely's pelvis, as I told, it is an, so one ala of sacrum only is absent, and most of the times this becomes a congenital disorder because of arrest. Okay, arrest of one ala of the sacrum, that is mostly due to an acquired condition, say acquired condition like osteitis, okay, of sacroiliac joint. Clear? So, these are the two anomalies you have to know, right? Okay. Now, let us pass on to the placenta. Okay. So, in placenta you have a lot to discuss. Okay. Right now, I will be starting from the development of placenta and taking you through all the possible anomalies and disorders that are associated with placenta, right? Okay. Now let us identify the sites of placenta. Okay. So, if you see this placenta, this is having a shiny surface. That means it is covered by membranes and you have the umbilical cord attached, right? Then when you see the side, it is appearing somewhat rough and you have like so many depressions and so many things, right? Okay. So, if you see this, what you will do? So, if you see a shiny surface with membranes attached, it is going to be the, yes, very good, it is going to be the fetal surface of the placenta, whereas this means it is going to be the maternal surface of the placenta. Clear? Right. Now, let us discuss something about the development of placenta so that you will be understanding the following concepts. Okay. So, what happens is actually when the blastocyst is getting implanted, the endometrium of the uterus is going to convert into something called as decidua. Okay. And as the blastocyst implants and the embryo is going, the decidua will be having three components by itself. Okay. So, the place where the embryo has attached itself going to be the decidua basalis, and the part that is covering the embryo is the decidua capsularis. Okay, it is going to be the decidua capsularis and the rest of the thing is going to be the decidua parietalis, right? And the same way, chorion also has two layers. One is chorion frondosum, which is an attachment with the decidua basalis is going to be the chorion frondosum, and the rest of the thing will be chorion levae, right? So, once again let me tell you regarding decidua, we have decidua basalis, which is between the embryo and the uterus, and then decidua capsularis, which is covering the anembryonic pole, okay, which is covering the anembryonic pole. Okay, capsularis is like a cap that is covering, right? And finally, we have the decidua parietalis, which lines the uterine cavity except the site of implantation, Clear? So, these are the parts of decidua. Similar way, you have parts of the chorion also. Okay. So, chorion frondosum is something that is attached with the decidua basalis. Okay. And this chorion frondosum and decidua basalis are only going to develop into the placenta. Then, chorion levae is attached to the decidua capsularis, and this basically degenerates because it does not get any proper nutrition. Okay. Complete placenta is formed by 12 weeks, and by this time the uterine cavity is obliterated. Okay. So, if you see the layers from the fetal to the maternal surface, the order of layers in the placenta will be like this. Okay. So, first we have the amniotic membrane, then we have the chorionic plate, then we have the choriodecidual space with placental villi. Also, you have the decidual villi. Okay. Sometimes in term placenta and all, you will be able to see whitish deposits also. These are nothing but the calcium deposits, and as the pregnancy is getting towards delivery, okay, as the pregnancy progresses, you will be able to see more of white deposits, which are nothing but calcium, and these doesn't have any significance, right? Yes. So this is how it will be, right? Okay. Now let's discuss about the anomalies of placenta. Okay. So normally what we saw, we had only one lobe of placenta like this, right? So this is the normal thing. But if you see here, you are able to see two lobes of placenta, right? So what do you call this? It is called as a placenta bilobata. So this is called as placenta bilobata or placenta bipartite or even placenta duplex. Okay. So you have two lobes. Okay. Suppose if you have more than two lobes, then you will be calling it as placenta multilobata. Clear? Yes. So what you see here is basically two equal lobes. Okay, almost two equal lobes you are seeing. Okay, that means placenta bilobata. Suppose you have one big lobe and you have another small lobe. What do you call it as? Yes, it is going to be placenta succensurata. Very good. So this is going to be your placenta succensurata. Right? Yes. So we have some importance for this placenta succensurata. You have to know there is 3% incidence of placenta succensurata in females, and you have a separate small lobe away from the main lobe, and these are connected by the vessels also. Okay, so that is also another important point. What happens is, soon after delivery, we'll be thinking most of the times the placenta has only one lobe and we'll be delivering the main lobe alone. Sometimes, if it is a placenta succensurata, the small lobe may get retained inside, and retained placenta will be the most common cause of what? Yes, it will be the most common cause of secondary PPH. Okay, yes. So retained lobe after delivery becomes a cause of secondary PPH. Also, there can be chances of infection as well as subinvolution, right? Yes. Now, we have another thing like this, similar thing like this, that is placenta spuria. Placenta spuria means there is one small lobe of placenta that is away from the main lobe, but they are not connected by vessels. Okay. So, you have a big lobe, you have a small lobe separately. Okay. So, this vesicular connection is not present. That is placenta spuria. Clear? Right. Now, so these are two placentas which look almost similar to each other, but there is so many difference to note. Okay. Yes. So, what do you think this is? This is your circumvallate placenta. How I identify this as circumvallate placenta? Because the marking, okay, so this ring-shaped thing which is very prominent here, and you are able to see the vessels are coming like this, but soon after this marking you are not able to trans the vessels, right? So this is going to be circumvallate placenta, okay. And if you see here, in this placenta, the vessels are also not prominent, and one more thing is, this transition here seems to be very smooth, right? This transition seems very smooth. It is not like here. Okay, here you see that this center part where the vessels are present are going to appear like a depression, whereas this has a ridge-like elevation, right? These membranes are having a ridge-like elevation, but here the transition is very smooth. So this type of placenta is called as circummarginate placenta. Okay, right. Now, In both these types of placenta, your chorionic plate, okay, that is the chorionic side, chorionic frontosome is going to be much less when compared to your decidua basalis, that is your basal plate. Clear? And membranes are folded on themselves. That's why the thickened membrane is present. Okay, in both the things the membranes are thickened only. Okay, but it is more prominent in your circumvallate placenta, right? So membranes are folded on themselves. Okay, so here also you will have so many complications. The complications expected can be abruption, it can result in antepartum hemorrhage or preterm labor or even fetal growth restriction. Clear? Now, if you see this picture, you will be able to understand about the formation of normal placenta and these two different types of placenta. Okay, so normally what happens, your decidual plate, that is the decidua basalis plate, basal plate limit and chorionic plate limit are going to be the same. Okay, see here, both are merging here, it is going to be the same. Whereas in your circummarginate placenta and circumvallate placenta, it is going to be different. And one more point you have to notice, in circumvallate placenta, the membranes are going to fold it upon themselves so that the prominence is more. Clear? Right. Now, yes, coming to the location of placenta. Okay, that is the site of placental attachment. Okay, normally where it is attached, most of the times placenta is attached in the upper posterior segment of the uterus. Clear? So that is the normal attachment. But a placenta attached in the lower segment of the uterus is called as, yes, it is called as placenta previa, right? So this is placenta previa. Okay, yes. So we have three types of placenta previa. Okay, so this is a normal attachment, right? So this is normal attachment, and here we have three types of placenta previa. If you see, the placenta here is going to touch the internal os, but it is not covering the internal os. So we call it as marginal placenta previa. And here, yes, it is coming to the internal os, but it is not completely closing it, right? Suppose if the os is going to dilate up to 10 centimeters, then there is a chance that this placenta will be carried to the other side of the uterus, right? Can you imagine? So that means this placenta is going to be a partial placenta, and here if you see, the placenta is completely blocking the internal os, so that even if there is 10 centimeter dilatation, there is no change in the placental position. The fetus will be going and compressing the placenta itself directly. Okay, so this is going to be a total placenta previa. Clear? So this is one of the oldest classification. So we have type 1 placenta previa, where the placenta is implanted in the lower uterine segment, but the placental margin is not touching the internal os, right? Next is type 2 placenta previa. It is also known as marginal placenta previa. Okay, so what is happening here? It touches the margin of internal os. Okay, but it is not covered by, the internal os is not covered by placenta. Next is type 3, where the internal os is covered partially. So it is partial placenta previa. The internal os is also covered partially. Then finally is type 4, that is total or central placenta previa, where the internal os is completely covered by the placenta. Okay, so this is one of the oldest classification, but it will be easier to understand. Okay, but now we have a new classification that is called as NIH classification, which is the latest classification for placenta previa. So what is happening is, we will be taking these two types together. Okay, so that is placenta previa itself. Okay, the placenta previa itself, that means what? It is going to be covering the internal os either partially or completely. Okay, that is partial placenta previa or a total placenta previa. And these two things are taken as low-lying placenta. okay, low lying placenta. Okay, that means the placenta is touching the internal os, or it is touching the margin of the internal os, or even 2 centimeter away from the internal os. Can you understand? Yes, right. Now, when you have a placenta previa case, how you are going to manage? So, when you have placenta previa, first you have to check the gestational age. If it is less than 37 weeks, okay, and if the patient can have no or minimal bleeding, that will be active bleeding, right? Then there can be, you have to check for the fetal condition, which may be good or bad. Also, you have to check the fetal abnormality, okay, either plus or minus, and finally we will be checking the maternal condition as well. Okay, this can also be good or bad. So, if all the 4 points are positive, then we can go for McAfee-Johnson regimen. Okay, so this is a expected regimen for placenta previa. Suppose if any one is negative, okay, if any one is not favorable, then we will go for delivery immediately. Clear? Right? And suppose if it is more than 37 weeks, we can't wait, we have to deliver the baby immediately. Clear? Yes. So, this is about the management of placenta previa. Now, let us see the difference between placenta previa and abruptio placentae. What is placenta previa? Placenta previa is the abnormal attachment of the placenta. It will be attached in the lower uterine segment. What is abruptio placentae? It is the premature separation of the placenta. That is, the placenta is going to separate itself from the uterine wall before the onset of labor itself. Clear? Right. So, it is placenta previa and abruptio placentae. So, the points we are going to discuss is about the nature of bleeding, then how will be the character of blood, then we have to see about the height of uterus, okay, while you examine, then how will be the feel of uterus, also how will be the fetal hot sound and any other abnormalities or cause associated. Okay. So, if we see the nature of the bleeding in placenta previa, it will be a causeless bleeding and it will be coming as warning beams, repeated recurrent bleeding that is without any cause, that is placenta previa. Okay. So, it is also painless. So, painless and causeless, also recurrent, that is placenta previa. Whereas, in abruptio placentae, the bleeding is going to be painful, okay, as well as it will be continuous, okay, and not always the abruptio placentae bleeding is revealed, okay. So, that means the bleeding can be concealed or it can be revealed, okay. So, it can be either. Next is character of the blood in placenta previa is usually a bright red color, whereas in case of abruptio placentae, this is a dark colored blood. Then height of the uterus in placenta previa is going to be proportionate to the gestational age. Whereas in case of abruptio placentae, imagine if there is a concealed bleeding, the blood is also getting collected inside the uterus, right? So, there will be disproportionate between the height of the uterus and the gestational age, right? So, there is disproportionate uterus. Feel of the uterus, usually the feel of the uterus is soft and relaxed in case of placenta previa, whereas in case of abruptio placentae, this is not relaxed, usually this is tense, tender and rigid, okay. And in case of placenta previa, the fetal heart sound is always and always present. Okay. In abruptio placentae, depending upon the grades of abruptio placentae, the fetal heart sounds can be present or it can be absent. Okay. So, the most common abnormality that can be associated with placenta previa is nothing. Okay. So, mostly there will be nothing that will be associated with placenta previa, but in abruptio placentae you have so many causes, and the most important cause we have to remember is hypertension. Yes, hypertension. But abruption can also occur due to severe trauma or multiple gestation, then polyhydramnios, like that. So, these are the causes. Okay. So, finally, what I want to tell you is placenta previa is nothing but placenta located in the lower segment. Abruptio placentae, placenta can be located anywhere. It can coexist even with your placenta previa, but it is a premature separation of placenta. Clear? Right. And that's why while you are doing a pervaginal examination, before doing it itself, you should be sure of where the placenta is located. Okay, so ultrasonogram should confirm the location of placenta before you are performing your pervaginal examination. But a transvaginal probe can be used to examine the location of placenta because the probe lies short of the cervix. Okay, it won't be going and hitching the os of the cervix. Okay, a transvaginal probe can be used, but PV is contraindicated without knowing the placental location. Clear? Right. Now, let's discuss about the grades of abruption. Okay. So, grades of abruption, we have 4 grades. Okay. So, grade 0 is where the patient is mostly asymptomatic, and abruption is discovered only after delivery, where it will be asymptomatic, and abruption is mostly discovered after delivery only, where it will be seen as a retroplacental clot. Right. Next is grade 1 abruption, where there can be vaginal bleeding and mild uterine tenderness, but no maternal or fetal complications. Okay, you have no maternal or fetal complications. Next is grade 2 abruption, where you will have fetal distress or death. Okay, you have fetal distress or death. And finally, we have the grade 3 abruption, where you will get maternal complications, right? So, maternal complications like shock, renal failure, coagulopathy, or even death. Okay? Yeah. So, this is what you have to know. Okay? These are the grades of abruption. Next, what you have to know is, you have to know, as I told you, there are 2 types of accidental hemorrhage or abruptio placenta, which is going to be concealed type, that is, the bleeding is not revealed, otherwise it can be revealed type as well, or both can coexist, that is mixed type of abruptio placentae. Clear? Now, yeah, so this is a revealed type of abruptio placentae and this is a concealed type of abruptio placentae. So, revealed means the bleeding you are able to see, okay, you will be able to see the visible loss of blood, whereas in concealed type the blood will be collecting behind the placenta, that is, it will be collecting as a retroplacental clot. Now, tell me which is going to be the most dangerous one? Yes, it is going to be the concealed type, right? Yes. Now, let us see the difference between these two. So, in revealed type, you will be able to see dark colored, because abruption itself is a dark colored bleeding, right? So, dark colored bleeding that will be up to moderate level, okay. But here concealed bleeding will be very slight, okay. It can be present, but it will be very slight, or it can present as a blood stain discharge. The patient won't be able to realize that it is a bleeding as it is. Okay, yes. And in revealed type, the general condition of the patient is proportionate to the blood loss, whereas it is not proportionate here. Okay, it is disproportionate here. And the fetus of shock are usually absent in case of revealed hemorrhage, because as soon as the bleeding is happening, the patient will be rushing to you. Okay, whereas here the bleeding will be happening. Patient will be thinking, okay, some discomfort will be having, we are not having any other visible symptoms. So she may be there till she develops so many complications, like she may develop features of shock. Okay, yes. And fetal parts can be easily palpable in case of revealed hemorrhage, whereas it will be difficult to palpate here. Okay, and fetal heart sounds are usually present here. Here it is usually not present, and also oliguria can be seen in case of concealed hemorrhage. Okay, whereas in case of revealed hemorrhage, you will have normal urination. Okay, so these are some of the important points of revealed hemorrhage and concealed type of hemorrhage, right? Yes. Now, yeah, let's discuss about this one. So, what do you think this is? This is a covular uterus. Favorite one, right? This is a covular uterus. Okay. So, let me discuss what is happening in this uterus. Why do you get a picture like this? Okay, usually the whole uterus will be pink in color as you do a hysterectomy, right? But here if you see, there are so many dark areas in the placenta. What do you think these dark areas are? These are nothing but the hemorrhage. The blood has extravasated into the myometry layer and it is visible through the serosal layer of the uterus. Okay, so that's what has happened. So, there is widespread extravasation of blood into the uterine musculature and also into the uterine serosa. So, this color of the uterus becomes portwine color, and this can be either patchy or diffuse. Okay, so this is what we call as covular uterus. It has also got another name, that is retroplacental apoplexy. Okay, so it is usually found in severe form of concealed accidental hemorrhage. Okay, and this is also found as a incidental finding during a laparotomy, right? And remember, this hemorrhage may not be present only at the uterus. It may even go into the surrounding structures like your broad ligaments or even your tubal serosa, ovaries, also into the peritoneal cavity. Okay, but this bleeding would not interfere with the contraction of the uterus and never be a cause of PPH. And so, as soon as you see this covular uterus, no need to perform hysterectomy. Okay, so remember, no need to perform hysterectomy for this indication itself, and there is no need for any specific treatment also. Okay, so this is just a observative finding that you see when you have severe concealed accidental hemorrhage or concealed abruptio placentae. Okay, right. Now, yes, let's speak about this thing. So, what is all these together called as? All these together are called as placenta accreta spectrum, right? Placenta accreta spectrum. So, you have to know, normally the placenta is going to attach itself to the endometrial layer. Okay, so this is the normal attachment. Okay, so it will be present in the deciduous layer only. Okay, there will be a plane of cleavage between the placenta and the endometrium of the uterus always, right? But there is adhesion between the placenta and the endometrial layer, or if the placenta is invading itself into the myometrial layer, or the placenta is invading into the serosa layer. They are given separate names and together it is called as placenta accreta spectrum. Okay, so when it is only adherent, it becomes placenta accreta. Okay, when it is invading through the myometrium, it becomes placenta increta. When it perforates the serosa and comes out, it is placenta percreta. Clear? Right. Now, let us learn about the ultrasound features of placenta accreta spectrum. Okay, so the ultrasound findings of placenta accreta spectrum. First one, there is loss of normal hypoechoic plane in the myometrium beneath the placental bed. Okay, beneath the placental bed. Okay, normally you have a hypoechoic plane between the myometrium and the placental bed, but it is not seen in placenta accreta or any type of placenta accreta spectrum, right? And the second one is there is presence of multiple placental lacunae. Next point is there is loss of the normal hyperechoic line that is separating the urinary bladder wall from the uterus, and you will also have thinning of the myometrium. Myometrial thinning will be there, that will become less than 1 millimeter. And finally, you will also see bulging of the placenta into the surrounding tissue, okay, into the surrounding organs that are adjacent to the uterus, that will be seen like a mass that is protruding from the uterus into the adjacent organs, right? Okay. Suppose if the placenta accreta is occurring on the lateral walls or posterior walls, then it will be difficult to diagnose through ultrasound. That time you may need an MRI for investigation, right? Okay. Now, let's see these pictures. Yes. First one, you are able to see a urinary bladder and there is heterogeneous placenta with abnormal placental lakes. You are able to see numerous placental lakes like this, okay. And also there is thinned out myometrium indicating the placental invasion, okay. So, this is only the myometrial layer which is thinned out because of the placental invasion, right. And as I told you, because the placenta is protruding out through the serosa, what happens? This will be seen as a protrusion into the adjacent organs. It will be coming from the uterus and it will be protruding into the adjacent organs, okay. So, the myometrial thinning will be there, okay. So, usually normal myometrium will be like this, okay, this much thick, whereas in case of PA spectrum, the myometrial thickness will be very much reduced, that is, it will be less than 1 millimeter. And what else you see? You see absence of the retroplacental zone, you will be able to see placental acne, and the bladder line interruption will also be seen, okay. So, no need to remember this exactly, but you should have an idea. Suppose in the USG picture or in a clinical question, like anywhere they have mentioned any of these features, means this is pointing towards placenta accreta spectrum, right? Yes. Now, let us see about the umbilical cord. So, what we are seeing here is the normal attachment of umbilical cord. Normally, an umbilical cord is attached to the center of the placenta. Okay, so this is normal attachment of umbilical cord. Okay, whereas if you see this placenta where the umbilical cord is attached to the margin of the placenta, what is called as? Yes, it is called as battledore placenta, right? Okay, so it is called as battledore placenta, right? The cord is attached to the margins here, right? Now, let us also see, now what is the significance of this battledore placenta? Yes, there can be compression of the cord during delivery that will be resulting in fetal anoxia. Clear? Right. Now, let us talk about these three figures. Okay, so what do you have here and here and here? Yes. See, this is the normal attachment of the umbilical cord. Okay. So, here you are able to see exposed blood vessels, but remember the fetal head only, it's lying near the lower segment, right? Okay. When you imagine if you are doing a PV, you will be touching the fetal head alone. So, this will be your filamentous insertion of cord, whereas in this pic you are able to see that the vessels are running below the fetal head. So, if you do a pervaginal examination, you are going to touch the blood vessels of the cord, which are going to be the blood vessels of the fetus. Okay, so this is a Vasa Previa condition, right? Yes. Now, let us talk something on these conditions. So, as I told, what is filamentous insertion of cord? Umbilical cord is not attached to the placenta, right? Instead, it is attached to the membranes and the vessels pass through the membranes, okay, and the vessels travel through the membranes. And the next one is Vasa Previa. Here you have leash of blood vessels that lie in the lower uterine segment below the presenting part. Okay, whatever may be the presenting part. Okay, below the presenting part, these vessels are seen. Suppose if there is a artificial rupture of membranes or even a spontaneous rupture of the membranes, what is going to happen? You will be presenting as vaginal bleeding. Okay, you will be seeing vaginal bleeding, and this bleeding is not from the mother. That is the difference. Okay, placenta previa or abruption placenta is the bleeding that is coming from the mother. But in case of this Vasa Previa, the blood is coming from the fetus. Okay, so this is fetal blood. Suppose if you have any doubt, we can perform two tests to diagnose whether it is fetal blood or maternal blood. The tests are alkali denaturation test or Singer's test, and the second test is Clare Bedke acid elution test. Okay, so these are the two tests you can offer to differentiate maternal blood from the fetal blood. Clear?